Hello, my name is Millie Dolce, and I am a Program Evaluator Analyst for Wellness Initiatives at Nationwide Children's Hospital. And I'm here today to speak with you about social determinants of health and child health. At NCH, I am embedded in what's known as the Healthy Neighborhoods, Healthy Families Initiative. This initiative is composed of faith-based organizations, community development organizations, workforce development programs, youth-serving nonprofits, and local public schools. The goal is to create positive health outcomes in the community. HNHF began on Columbus's south side, which you can see on the map here, and that's the area around Nationwide Children's. The HNHF initiative targets 5 impact areas: economic development, affordable housing, community enrichment, education, and health and wellness. So we know that we cannot reach our public health goal of achieving optimal public health until we achieve it for everyone. So today we're going to talk about disparities in health and healthcare, social stressors and hardships that produce these disparities, strategies for addressing health equity, and some examples and lessons learned from NCH. And woven into our entire discussion will be themes related to social determinants of health. So by the end of this talk, I hope you will have a greater understanding of how and why social determinants of health are important and some ways to address them potentially. So to get us all on the same page, we're going to briefly review some definitions. The first is health disparity. Health disparity has to do with differences in health outcomes across subgroups of the population. Health disparities are often correlated with social, economic, and environmental disadvantages, like not having access to reliable or affordable transportation, not having a job that produces a living wage. It's important to note that just because we see a difference in health outcomes does not necessarily mean there is a disparity. We call something a disparity only when there is no biological reason for that difference. Now, healthcare disparities refers to differences in access to or availability of health facilities and services. Another definition is health equity. Health equity means that everyone has a fair opportunity to live a long, healthy life. It means that health should not be compromised because of an individual or population group's race, ethnicity, gender, income, etc. It's important to note that equity and equality are not the same thing, and this diagram shows that. So equality has to do with making things fair, which means giving everyone the same amount and type of resources. In this picture on the left, everyone is given the same size step stool, but not everyone can reach the registration counter. Equity, however, has to do with helping everyone achieve the same outcome. This means that resources are given out differently based on need and circumstances. And as you can see on the right, different resources are given to the children so that everyone can reach the registration counter. So providing health equity does not always mean treating everyone equally. Now, there are some segments of the population that are more likely to experience disparities than others. These include racial and ethnic minorities, individuals who have low socioeconomic status. We see disparities based on gender. We see disparities based on being a member of a differently abled population. We see disparities based on language and language proficiency. We see disparities based on sexual orientation. We see disparities also based on geographic region. Now, I have a few comments to make about race and ethnicity before we continue. We are going to look at some data broken down by race and ethnicity. Sometimes people use these terms interchangeably, but they are actually distinct constructs. Race has to do with being a member of a large group of people who share a common ancestry or heritage. Ethnicity has to do with being a member of a large group of people who share a common culture, religion, or language. It can definitely be challenging to collect race and ethnicity data, but it's good to remember that the gold standard is for individuals to self-report. It's also important to remember that race is a social construct, meaning how individuals are grouped together based on heritage and ancestry is arbitrary, and it's not based on biology or genetics. The primary reason why the government asks us to collect race and ethnicity data is for the enforcement and evaluation of laws prohibiting discrimination. Now we're going to look at some examples of health disparities. This is a map of overall healthcare quality in the United States. The Agency for Healthcare Research and Quality gave each state an overall healthcare quality score. The scores were ranked and divided into 4 groups. States with the highest score have the overall best healthcare quality, and they are in blue. States with the lowest scores have the lowest overall healthcare quality, and they are in gray. And as you can see, there's a lot of variation in the healthcare quality across the country. Northeastern states have some of the highest healthcare quality, while southern and southwestern states have some of the lowest. This map is similar to the previous one, except it looks at overall healthcare quality by race and ethnicity. Here, the AHRQ looked at differences in overall healthcare quality for whites compared to Blacks, Hispanics, and Asians. Small differences mean less disparities in healthcare quality, and large differences mean greater disparities. Again, you can see a lot of variability across the country with higher disparities in the Northeastern and Midwestern states. Now, there are not only disparities in healthcare quality across the nation, but also within our state. Looking at just Ohio now, we can see disparities in healthcare quality by race, ethnicity, and also county type. This data comes from the Ohio Medicaid Assessment Survey. The data here is just for women, but it represents overall population trends. Non-Hispanic white women report higher healthcare quality than women from other racial and ethnic groups. Women in Appalachian counties report lower healthcare quality compared to women from other county types. This slide is looking at women who rate their health as poor. You can again see racial and ethnic differences with non-Hispanic Black and Hispanic women rating their health as poor more frequently than women from other racial groups. Looking at maternal and child health, we see similar pictures. Black and Hispanic women in Ohio have higher rates of preterm birth, which is a negative health outcome. We see the same thing when we look at teen pregnancy rates for 15 to 19-year-olds. Ohio, unfortunately, has a long history of racial disparities regarding infant mortality. This graph shows us trends in Ohio infant mortality rates by race for almost 30 years. The blue line is the state average infant mortality rate. The purple line shows the infant mortality rate for whites, which, as you can see, is considerably lower than the state average. The green line is the infant mortality rate for Blacks, which is sometimes more than twice that of the state average. There are also disparities by region and county type. This slide shows that for asthma, substance abuse, and dental health, Appalachian and rural counties more often have worse health outcomes than other county types. So, in summary, we examined health disparities related to particular health outcomes by race, ethnicity, and region. And we saw pretty much across the board that non whites generally report worse health outcomes than whites. And we also noticed some regional differences. But what can we do? Knowing that there are disparities is not enough. The conversation doesn't end there. How do we begin to achieve health equity? Well, here are three strategies that have been taken to work towards eliminating health disparities. The first is to provide the best care we can in clinics and hospitals. The second is to identify social stressors, or in other words, social determinants of health that we will talk more about later, while people are in clinics and hospitals. And the third is to address social stressors, aka these social determinants of health, in the community. This includes developing partnerships between healthcare settings, community members, and other types of community-based initiatives. So I mentioned trying to identify and reduce social stressors. We all have stress, right? And certainly it would be nice if we can eliminate it, but that's likely not going to be possible. So I'm not just talking about regular amounts of stress. I'm talking about toxic stress. Toxic stress is the prolonged activation of our stress response system where there's nothing to help buffer between that stress and us. There's an absence of protective relationships. So why does toxic stress matter? Toxic stress matters because it can actually result in changes in our brain architecture. It can also result in epigenetic changes. That means our environment can actually impact our gene expression, meaning which genes are dormant or turned off and which genes are active or turned on. Lastly, toxic stress can also cause inflammatory responses in our bodies. And all of these things taken together can lead to developmental delays, substance use, heart disease, diabetes, and depression. Toxic stress is caused by chronically being exposed to things like physical or emotional abuse, having a caregiver with an untreated substance abuse or mental health issue, being exposed to violence, having some type of family hardship like an economic burden. There are other types of chronic exposures too, such as poor neighborhood and school safety, a lack of quality education, and food insecurity. And there are definitely disparities in who is being chronically exposed to some of these things and who isn't. Let's take a closer look at neighborhood and school safety. This data is for the state of Ohio. It shows that parents of white children report their children living in safe neighborhoods more than parents of Black children. We see the same thing with children attending safe schools. Parents of white children report this happens more than parents of Black children. This is a heat map of high school graduation. This data it's a little old, it's from 2015, but it tells a startling story. The darker the color, the lower the graduation rate. You can see that more of the concentrated urban counties have lower graduation rates than other county types. For example, you can see a big difference between a 96.7 graduation rate for Delaware County versus a 67.3 graduation rate for Franklin County. This is another heat map, and it's for food insecurity. Again, the darker the color, the higher the percentage of food insecure children. You can see a heavy rate of food insecurity among southeastern and Appalachian counties. There's also in our state a disparity with race where Black children have higher percentages of food insecurity than white children. Now, in building our discussion on social determinants of health, which we will get to directly very soon, It's important to acknowledge how these social stressors that we just examined, neighborhood safety, school safety, education, and food insecurity, can impact health and child development. And as we have just examined how some segments of the population experience these at greater rates than others, please keep in mind that this can lead to some subgroups of children experiencing the following health and child development outcomes disproportionately more than others. But first, I want to show you evidence of how our environment impacts health. This was a project completed by the Virginia Commonwealth University and Robert Wood Johnson. They estimated life expectancy solely based on the zip code you were born in and other vital statistics from that area. They didn't know your family background, your current health history. All they knew essentially was the zip code that you were born in. This is a map of Cleveland, and as you can see in a relatively short distance, the life expectancy changes by 12 years. Where we live drastically impacts our health. So getting back to the impact of social stressors on child development, unmet social needs can negatively impact health. It can lead to chronic conditions such as asthma and obesity, poor language development, infant mortality, risk of injury, lack of access to treatment. Unmet social needs can also negatively impact behavioral health, such as depression, anxiety, developmental delays, impaired social functioning, and challenges regulating, controlling emotions. Unmet social needs are also associated with the following school outcomes: lower kindergarten readiness scores, lower reading and test scores, lower school attendance, lower high school graduation rates. So one thing you may be wondering is, how can you tell if a child is experiencing some of these social stressors? We certainly cannot assume that everyone from a particular racial or ethnic background or county type is experiencing the same social stressors in the same way. So how can you tell? Well, in the health system, at least, here is how it may look. And some of this may apply to some of your settings. It may look like a family or patient who is not compliant or not following through with treatment plans. It may look like not being engaged with care. It may look like repeatedly using the emergency department. It also may look like repeatedly being sick or having minor health problems. But this may really show that there's a language barrier or a health literacy issue, that there's something in the communication that's being broken down. It may illustrate a lack of transportation or not having enough food. It may also be symbolic of poor housing conditions. So why isn't clinical standardization enough? Why can't we just do that first strategy, be doing a really great job in clinic, and then have everything be okay? Well, that's because our health outcomes are influenced by a variety of factors, and only 20% of our health outcomes are influenced by clinical care or by what happens when we engage with the health system. 40% are influenced by socioeconomic factors like education and income. 10% are influenced by the physical environment like water and air quality and where we live. 30% are influenced by health behaviors such as diet and exercise, or lack thereof sometimes, and also substance use. These are social determinants of health. They are the conditions and the places where we live, learn, work, play, and are born. and they affect a wide range of health risks and outcomes. Now I'm going to show you a few examples of what we have done and are doing at NCH to be more mindful of social determinants of health and working to address them. I'm going to particularly talk about two things: a food insecurity screen and a social determinants of health screen. So first, with addressing food insecurity, what is food insecurity? Well, food insecurity is the lack of access to enough food for an active, healthy life for everyone in the household, in limited or uncertain availability of nutritionally adequate foods. It was estimated in 2015 that about 13 million children, or 1 in 6, lived in a food insecure household, and this has a negative impact on health. Feeding America estimates that of households that were food insecure, about 24% had at least one member in poor health. 33% had a household member who had diabetes. 66% of food insecure households had to choose between food or medical care, and 58% had at least one member with high blood pressure. So we had a goal to identify food insecurity in the patients that we were serving at some of our primary care clinics. So we had a team of interns survey patients in the lobby at 10 of our primary care clinic locations during the summer of 2017. And of the nearly 1,500 patients that we approached, 734 completed our paper and pen screen. 54.2% of them identified as food insecure, and they were given resources by our team. Also in 2017, Nationwide Children's Hospital developed its latest strategic plan that went from 2017 to 2022. In it, for the first time, we identified wellness and population health as an accelerator to best outcomes. Part of our mandate was to implement a screen for social determinants of health across the institution. Our goal is to identify social needs that patients have when they are in clinic and then help connect them to resources either at the hospital or in the community that can address them. We ask all patients these questions once a year. We ask them first and foremost for their permission to ask them questions. And we also have a brief introductory statement that lets them know that we're asking all patients these questions. So hopefully no one feels targeted. We also let them know that we have team members who may be able to talk to them about resources. Then we have questions that ask about food, housing, transportation, and utility needs. We also ask a second tier of questions, if anyone answers affirmative to the other questions, that try to get at urgency. And if those needs are acute and urgent, then patients and families are given the opportunity to receive a social work consult and a warm handoff towards resources and assistance as necessary. If the needs are not urgent, then patients and families are given this resource sheet, which we designed in conjunction with our social work department, as well as our language services. This resource sheet is divided into different sections. We have a section related to COVID, related to emergency type services, related to services that can help when it's not an emergency, for resources outside of Franklin County. And then we have listed some cultural or ethnic community agencies that might be able to provide culturally informed services. And if anyone is interested in using this, I'd be happy to share. We also have this available in 5 other languages besides English, and that is Spanish, Somali, Nepali, French, and Arabic. So here are some lessons learned. We learned that it's actually possible to ask families sensitive questions in different contexts. And I hope that these lessons learned may translate to some of your settings, that it is actually possible to, in a respectful way, ask families if they have some unmet social needs. We have done this in our emergency department, in our primary care, and in many other settings. Sometimes it seems uncomfortable, but overall families have been receptive. And we continually look to ask in ways that show respect and compassion. We've also learned that there's a lot of trial and error in this process of making sure that we are asking questions and setting up expectations appropriately related to the resources that we can and cannot provide. We've also learned that it's really important to keep resources up to date. Especially during the pandemic, resources have changed very rapidly. So having even one place to direct families to where they can get the most up-to-date resources has been helpful. We've also found that it's useful to explore different ways of asking questions. We sometimes have asked patients using paper and pen forms. We've asked them using iPads, and we've had staff verbally ask them questions. So we're constantly trying to learn and evolve what is going to help families feel the most comfortable. And it's really not having clinic staff ask them the questions. So we're moving more towards trying to use technology to screen patients. And we've also heard from stories from families as well as staff that asking these questions can actually help families. We've heard stories where families have been struggling with certain things and they were not planning on disclosing that at the doctor's office, but when they were asked the question, it gave them the opportunity to disclose that, and then they were given resources that actually helped. So this has overall been a very positive thing. Now, I would like to close by posing a series of reflection questions. And we have discussed the prevalence of health disparities. We've talked about strategies to address them. We've discussed social determinants of health and shared a few examples from NCH. Now, these reflection questions, I think, can help you think about how you, in whatever setting you find yourself, can positively impact social determinants of health and some of the underlying stressors that cause them in your area. Now, remember, equity is not the same thing as equality, so there may be a need to advocate for or to distribute resources differently in order to help everyone achieve the same outcome. So the reflection questions, are: what are the communities of opportunity and low opportunity communities that you encounter? Or in other words, you can think of: who are the haves and who are the have-nots that you encounter? What values underlie decision-making in your area? Who benefits from the work, or I would say even policies or procedures that you have, and who does not? Who is at the table when decisions are made and who is not? Who is accountable to whom? And finally, what would it look like if equity was the starting point for decision-making in your area? If wanting to have everyone achieve the same outcomes was the starting point for how you made decisions. With that, I will thank you all for your time and attention. And if you have any questions or concerns or comments, here is my contact information. Thank you.